Jim? Hello, Jim?
Yes, sir.
Do you want us to stop our video as well now, or?
No, you can continue, sir. No worries.
Okay.
Karthik, we can get started, Karthik. 8.
Yes, sir. A very good evening to one and all. In a survey conducted in US, among the graduating medical residents, 73% of them chose the subspecialty of their mentors. If it has been conducted in India, it would be even more because we come from the education system of Gurukul. Pellegrini made note of two fundamental qualities of surgeon mentors. One, the ability to revel in succession planning for the next generation. Two, the skill of deriving personal satisfaction from the accomplishments of the students as direct and unspoken extension of the mentor's own achievement. Today, we have such wonderful people among us who are willing to share their experience and knowledge. Welcome to Ask Your Mentor Session 8. Over to Dr. Melita to introduce the moderator and mentors, please.
Thank you, Karthik sir. Our moderator for the day, Dr. Vimalambiga, completed her post-graduation in maxillofacial surgery from Ragas Dental College and Hospital, Chennai. Soon after completing her PG degree, she joined Ganga Hospital in 2006 and continues to work there till date. She has a special interest in maxillofacial trauma, TMJ-related surgeries, oral cysts, tumors, and jaw cancers. Our first mentor for the day, Dr. R. Manikandan, at present is Professor of Oral and Maxillofacial Surgery at Meenakshi Ammal Dental College and Hospital and Director of Cleft Unit at Meenakshi Ammal Dental College, Cleft Children International, Switzerland. He completed his undergraduate in 1990 and post-graduation in 1992. He completed his FDSRCS from England in 1996 and FFDRCS from Ireland in 1998. So far, Dr. Manikandan has operated around 9,000 cleft cases over a period of 21 years after returning from UK. Thank you for joining us today, sir.
Thank you.
Our next mentor for the day, Dr. Yasser Arafat, is an experienced oral and maxillofacial surgeon and member in Royal College of Physicians and Surgeons of Glasgow, UK. And in addition, got training in oral cancer ablation and reconstruction with over 10 years of experience in performing orthognathic surgeries, head and neck tumors, oral and maxillofacial trauma, and dental implants. He has also completed his fellowship in facial cosmetics and hair transplant. We are looking forward to an informative session, sir. Now over to Dr. Vimalambiga to moderate the session.
Good evening to one and all. I'm deeply honored to be the moderator for two very good sessions. First is cleft and craniofacial, and the other is a cosmetic session. So without wasting time, I should straight away go to the cleft and craniofacial session where your mentor is going to be Dr. Manikandan.
Thank you. Can I start?
Yes, sir.
Okay. Right.
Okay, so these are questions which the PGs have asked. So we are sticking to the questions that have been asked by the postgraduates. Okay, so this is the first question. Somebody wanted to know how to evaluate, diagnose, and come up with a treatment plan for cleft and craniofacial patients. Dr. Manikandan?
Thank you. Okay. Good evening, all. I just wanted to thank all the members of the AOCMF and the organizing team for doing these sessions, which is going to be very useful for the PGs. Now, without wasting time, I just wanted to start that, when I started my relationship and treatment rehabilitation for cleft lip and palate patient, I to be very frank, I never thought this could be so complicated that you need to have, so much of interaction you have to have with the patient and the relatives and other specialists. More or less, we always think that this is purely something related to an operation. Then we can send the patient home and do it. but it was totally different experience for me for the last 20 years. I will say, if a child is born with a cleft lip and palate, our commitment towards this patient will span for nearly about 20 years, maybe more than that, some cases. So it's just an ongoing relationship between different team members and the patient for a long period of time, which does not happen with normally with any other specialty, because whether you take orthodontic or you take cancer surgery, it's totally different. You know, it's a very small, of course, cancer surgery also need a long-term this thing. So when it comes to the question, it's very important to understand that the examination part of this child, when the child has been brought in, to understand whether the child has a syndrome or not, whether it's a purely cleft lip and palate. What happens in my center normally with, we ask one of our fellows to sit with the patient and the relatives, examine them, explain to them, counseling to be done. That is how we should really do it, that you know how to go about it really. Then the pediatrician sees, rule out any cardiac issues. So we need probably almost all the patients who comes to my center have an echocardiogram. We have such a huge database of patients with all these issues. We have to look into for the first 3 months how to gain the weight, including some nasoalveolar molding techniques. If there is a time available and patient is local and able to come, we do some nasoalveolar molding and plan technique and outcomes. That what is going to happen. We explain to them that the surgery for this cleft lip and palate patient are actually just not consistent of one surgery. This is going to be an ongoing 20 years of process. Please do cooperate with us. Unless you do it, the child will not grow, like a normal child. Of course, the child will require other diagnostic things like audiologist test after cleft palate is done, sometime before cleft palate. Most of our patients, we refer them to ENT to have a look at it, whether there is any medullary infection after surgeries or, whether the hearing is okay. Sometimes some of these children will have neurological issues. So we need proper neurophysician's opinion, psychosocial support for the children. Again, very important. Orthodontic intervention, starting from the age of 6 or 7 till the age of 20, 21. There will be a long period, probably the longest period in orthodontic treatment is in cleft. There's no doubt about it. So somebody who is have to be dedicated to do some cleft lip and palate orthodontic. And prosthodontic therapy, of course, they also help us in different stages. ENT assessment for hearing and of course, the cleft patient becomes, the next level. Can I change the slide from here, or do I have to ask you? Okay, thank you. So, when it comes to diagnosis, we have to know whether this is a cleft lip and palate, whether this is isolated, associated with the alveolus or a palate, bilateral, unilateral, all these things, syndromic, non-syndromic. After these things, you have to examine the patient, and once it is done, you have to put through all this team approach. Extremely important, the team approach. And this team approach till the 20 years is going to make the child beautifully like normal child. You have to probably do so many surgeries. So you need a systematic approach with all these specialists concerned to get a proper coordinated approach to make the child beautiful like any other child when he grows to 20, 21 years. Next, please. This is a very short scenario what we have put in. That is from the embryology. Normally, the first 4 weeks of gestation is a time that normally the cleft lip will be starting. First we can make out the 5th week, if somebody is doing a very good ultrasound scan, that can actually diagnose cleft lip. But many times the sonologist will not inform the parents because of the fear that they might ask the child to be terminated and other things. Unless you have a severe syndrome and the child is not going to thrive, then they inform. Otherwise, the child will not be informed normally. The parents will not be informed normally. If you look at the primary cleft lip repair, it is best done at the age of 3 months. We are coming to that back again and again, so I will explain a bit more. At the age of 3 months. Between this 0 to 3 months, one can do, if necessary, nasoalveolar molding so that you can get the shape of the nose during primary cheiloplasty in a better way compared to that of without doing it. It has been proved beyond doubt that nasoalveolar molding is going to help between 0 to 3 months. The palatoplasty can be done ideally between 9 months to 1.5 years, depending upon the weight, the facilities available, the speech starting, the hemoglobin. I will come into that again. So that is what is happening with regards to the palate. In the meantime, if somebody have a between 1 to 7 years, one can. Why that 1 to 7 years is very important? Because by the age of 7, normally what happens that the speech pattern is already set for the child. It becomes extremely difficult, even with a very good pharyngoplasty, one is trained with it and other things, to 100% make sure that you get a good speech. It is going to be very tough. So many consider that the cleft palate operation and the speech development have to be achieved by the age of 5 or 7, the best of it. So correction of velopharyngeal dysfunction, all those things have to be done very, very fast to get the best of the speech. If one is interested in intermediate rhinoplasty, you can do it as well. Between 7 to 12 years, if you see that 7 to 12 years, you can see the age down, you can see in the bar below that. One can, these are all transitions. See, there's nothing like specifically, this is the age you must do it. All these are certain proposed this thing. As one is doing it, you will understand, okay, this is in my center, in my hand, this is going to work better. And this is how to have to go about it. This is what I understood in the last 20 years. One has to do orthodontics. Probably at the age of 9, you can do, 7 to 9 alveolar bone grafting. Then when the child becomes, adult, something like 18 or 20, then you do orthodontic surgery. At the end of the day, once everything is done, you can go for a rhinoplasty. Next one, please. So here, what you see is, I just want to show you, this is actually, there are about 5 centers what I have shown. There's nothing like, this is what I said, there is nothing like, definitely, this is the way to do it. Okay, 3 months. If you see, out of 5 centers, all the 4 centers needed 3 months a lip. Okay, everybody followed different. Most of the 4 people followed Millard. Some of them followed Millard with the bomber and flap. Some of them followed tennis and rental. Purely surgeons' expertise, results what they're obtaining. So all the centers will have different protocol. It's nothing like if you are opening up a center and if somebody is doing it, in 20 years, you'll understand what are all the problems you had it. Okay, this is the way to go ahead. This is the way best result. So you will stick to that technique and you will try to get the best maximum optical out of it, the result out of it. So the first question is that very important to understand that there is no specific, written rules. All that you have to understand that as you are doing it, you develop your own protocol as per the place where you are operating, types of cases, what you are seeing it. Next, please. Okay, so that is to summarize that the parental counseling, very important. I keep telling all the patients, 20 years, 20 years, 20 years. I never speak about 1 year, 2 year, 3 years. Do come till for 20 years. Establish a good rapport with them, speak to them. You have to talk, a lot of things necessary to keep them happy, educate the children and so many things. Diagnosis and timing of surgery, very important. Staging, correct surgical technique and multidisciplinary approach, very important. Next one. Vipalambika, I think next question you can go for. Yeah.
This question that they asked was, 2 questions we put it. What is the ideal time of repair? This is both for cleft lip as well as cleft palate patients. And why is there a controversy in the repair time of cleft lip and palate? So the first question, Dr. Manigan sir will answer.
Yeah. The ideal time, I already mentioned, depend upon center to center. But in my center, in 95% of the centers around the world, they do the cleft, the cleft lip more than 3 months. 3 months and above onwards, you can do that. Minimum weight expected is about 5 kilo. And if for a good recovery and expect the palate is differ from 9 months to onwards. But then what we tend to do is that, we always ask, at least in private, in the hospital, we have a policy nearly about 12 months in our center. But in private, when I do something like that, I ask the baby that, the child is a relatively good weight, 9 months, and, and weight is okay. Hemoglobin is good. We start as early as 9 months, That's the time when the baby starts to speak. Some of the parents come and tell us that the baby is trying to say "amma" or the next up or whatever the words they're trying to say, and that is the time we normally start with it. So one can operate the palate definitely from the time of 9 months onwards. Any time after that, it is good. And as I told you, the faster is better. Okay, between 1.5 years is the best time. Between 9 months and 1.5 years. Thank you. Right, the next question, of course, was that why there is so much of a controversy. I already told you, there is no perfect time, perfect technique, perfect cleft, perfect surgery. It's very important to understand. Everybody learned from their experience, and the controversies is purely because of different aesthetic and functional outcomes in long term by different surgeons in different part of the world. Because everybody has put up their protocol. Okay, this is the way in our center it works like that, in their center it works. If you go to US, the protocol is different. Between intra-centers in US, different. Australia, you take, Europe, you take India, everybody done it different way. But there is common, as I already mentioned, there's a common, timing which we prefer to do it. But then it is not 100% okay. Within 3 months, if you don't do it, something can go wrong, nothing can go wrong. It makes it easy. This is the best time to do it. If you ask perfect technique, it's purely surgeon's choice. Okay, do you have a perfect cleft? It's very difficult. Some of the simple cleft sometimes we find difficult, but some of the complicated ones, it will be surprised that it comes as a good result. And there's not perfect surgeon as well, very important. Even with the perfect surgeons in the world, they still have some amount of difficulties in 20% of cases, some issues, this and that, and they have to do redo surgeries and everything. So it's all depend upon the type of cleft what you see it. I hope that answers the question. Thank you. Next.
The next question, yes. The next question is the role of C-flap in a Millard's rotation advancement technique of lip repair. Dr. Maligami?
Thank you. Right. So what you see here, that something, a small area of flap, what is mentioned there. See if you see here, this is a standard Millard. What is Millard technique is basically the non-cleft side have to be rotated down. The cleft side has to be advanced. So there are two things very important here. That is rotating the non-cleft side and advancing the cleft side. Because advancing, you have to advance towards the midline. And the non-cleft side, if you see towards the left side here in this particular slide, you can see it has to be brought down to get a symmetry of the cupid. So we get what is called, you can see here, what is called a C-flap. Okay, that C-flap. Can you use the mouse to show that, Dr. Vimalambi, please? The C-flap. I can't handle from here. So yeah, that's a C-flap. So you have a flap on this side, that is advancement flap. You can see that. Then the rotation flap onto the right hand non-cleft side, then the C-flap. So this C-flap goes up. You can see in the next one. Okay? There it goes up. And in the C-flap can be used for two purposes. Number one, it can be either used for reconstructing the nasal sill or the nasal floor, otherwise, in simple terms, or it can be used as a extra flap for lengthening the filter. So thus, these are the two basic uses of a C-flap. Okay, next diagram. Yeah, you can see it here. That is why I want to tell that. You can see here A, B, C, it is written. Okay, that is showing the three areas, three flaps which are there, rotated. And the C flap, you can see the C flap where it sits. The C flap sits exactly, it has two functions. This is very good diagram showing part of the C flap is used for the floor of the nose or nasal sill reconstruction. Part of the C flap is used for lengthening the filter length to make it symmetry between the left and right side of the lip. Okay, so this is very important as a C flap. Next one, please. And this is just, if anybody interested, they can go through these smile trend videos in the website. Shows beautifully that how the C flap is used. Thank you. Next one. So to summarize, what is the role of C flap? Closure of the nasal sill. Next one is columnar lengthening. Both are used for it. Next question, please.
So the next question. What causes the tongue to fall from between the palatal shelves during intrauterine life? Dr. Manigathan?
Thank you. It will take 5 minutes to explain. There are a lot of reasons, Always we know that there is something wrong happening in the palate. The palate is not closing. So there has to be some reason. Normally the palate closure happens. It starts from 6th to 7th week of face development, when the mandibles start growing ventrally, and you can see in the diagram, I think Dr. Vimalambika will be able to show it. Yeah, you can see that the 6th weeks on the top is a normal development. All the first stage, A, B, C slide on the top. That is normal palatal development. You can see the palatal shelves are down, the tongue is in between in the first diagram. Second diagram, the palatal shelves have gone up and the tongue has come down. Second diagram. The third diagram, the tongue has come down and the palatal shelves have gone up. So here you have three stages. This happens between 6 weeks or 7 weeks to 10 weeks to 12 weeks. Normally the palate grows and completes. Tongue has come down, the palate is closed. The lateral maxillary process comes and closes it, or palatal process of the maxillary. In a case of a cleft palate, you can see in the second row of the diagram, A, B, C, okay, D, E, F. See, the tongue is staying in the same place. The palatal shelf is not able to go up. And you can see here, thereby, since the palatal shelf is not able to go up, the tongue stays there. Palatal shelf is not able to come to close in the midline, so that there is no separation between nasal cavity and oral cavity. So that is the problem with it. Okay, next one. What are the reasons? Let us see one by one. There are many factors which have been told that why the tongue is not coming down. Genetic, drug exposure, cigarette smoking. All these are partly the reasons for palate formation as well. Okay. Now, couple of things very important. Early in the first trimester of gestation, they said there may be some mechanical factor, mechanical cause. Like, for example, they said that the neck can be flexed. The baby's neck, you can see in my this thing, neck can be flexed like this. The flexing of the neck, and that flexing of the neck will not allow the mandible to grow properly, and it will not allow the tongue to come down. So what is called as hyperflexion? It's called an abnormally flexed mandible towards the neck, towards the sternum. That will not allow the mandible to grow. And if the mandible is hyperflexed towards the sternum in the embryo level, the tongue cannot come down and mechanically obstruct it. Second very important theory they mentioned about is a reduced fetal movement. Okay, reduced fetal movement. I'll come into that. And there are other signaling factors also, whatever it is mentioned here. Next one, please. And there are a lot of research is going on in the mouse, and a lot of research have been going on. And they found that, like how a tooth erupt because there is an intrinsic force. Same way, there is an intrinsic force present in the palatal shelf that will come up, hold it, merge it together, and forms the palate, which is missing in many situations. Okay, which is missing in many situations. And can I go to the next slide? And that is very, very important. Let us say, for example, in a Pierre Robin sequence. Okay, you can see beautifully a Pierre Robin sequence. Many of you know that there is a glossoptosis and the mandible is deficient and the cleft palate. Classical triad of Pierre Robin sequence. Okay, first diagram showing the tongue is in the same position. Two palatal shelves are not able to come into the midline. Second diagram showing there's a severe mandibular retrognathia. The neck, that almost the mandible, anterior part of the chin is towards the sternum. So small mandible. It will not allow the shelf to go up. Third diagram is one of the beautiful diagrams showing how the tongue is stuck in the palate. Look at it. What you see like a small clover leaf is actually the tongue getting stuck in the palate. This is in a patient, a normal patient. When you open his mouth, you will find something like this, which is literally blocking the, palatine shelf to close it. So this is very important, and they have found specifically in cleft palate in PRS that what is called as a fetal movement mechanism. Okay, so if there is no proper fetal movement, very likely they say that cleft palate can come. Now the research is going towards how to improve the fetal movement in children at the age between 6 weeks to 12 weeks of intrauterine life, so that you can avoid these type of cleft deformities. Next one, please. Okay, of course, there are tobacco, using tobacco, alcohol, and some signaling factors like SHS or sonic hedge group. Next one. All these are, then there is something called as oligohydramnios. Sometimes they do amniocentesis, reduced fluid. You can hear sometimes gynecologists that the fluid is less in the uterus, and that can sometimes produce hyperplexion. Okay, very important. Again, the last point I want to discuss here is that the growth of the mandible. If there is a problem with the growth of the mandible, the tongue cannot come down. So it is like, and we call this an orchestra of events which is happening in the palatal shelf, tongue, mandible, everything together. Mechanical, environmental, as well as growth signaling factors. All the three constitute for the tongue to come down and the palate to close. Thank you. And of course, there are a lot of articles which are there in this thing. This is one of the new articles from 2020, which speaks volumes about all these things what I have mentioned. So please go through it. Next one. So I already summarized it. Next question, please. Yeah. Thank you. Please.
What is Diller's philosophy of cleft lip and palate repair?
Okay. Thank you. So we will take the question at the end, Dr. Vimalambiga.
Okay, sir.
Okay. Can you go back to one slide earlier? I'm sorry. I wanted to put this slide because these two gentlemen have to be, the pictures has to be seen by PGs who are also listening, because they gave the life to the cleft surgery in this world, to be very frank. Dr. Ralph Millard and Dr. Diller. Of course, both are doyens in surgery. Of course, probably something like, there's nothing to replace Millard's textbook, The Art of Cleft Surgery, and Diller explaining about the complicated the muscle mechanism, how you should reconstruct it. So Diller was Professor Diller from University of France, from Hospital Nantes. Millard was a plastic surgeon from US. Done a wonderful work on this and explained in detail how a cleft surgeon should really learn the artistic work of making this a normal babies. Okay, next one. There are two concepts which are mentioned by these two gentlemen. Okay, of course, Millard also has it. It is not that Millard doesn't believe in that, but Millard, after that, there is a lot of concept about how to correct. There are a lot of modified Millard approaches and everything. So here, the static concept. What do you mean by static concept? It is simple as that. Dr. Millard explains about different flaps That is advancement flap. We already discussed advancement flap, then the rotation flap, then the C flap, and all those things. With some amount of muscle correction. Okay? Get the best of the result. That is what the Millard concept was. But the Delaire concept, the philosophy was a little different. He said, concentrate on the muscle. That is what is very important. So he says it is called as a dynamic concept. That means redeployment of muscles establishes a vital function and structures which is buried and inhibited by the malpositioned lip and the nose. And very important to get that back in the normal position. That was the concept of, the basic concept of Delaire as it is. Next slide, please. Right, you can see here what happens in a normal versus abnormal. There is a strong, issue of having, strong issue of having malpositioned muscles starting from the transverse nasalis to the orbicularis, oris, and all these zygomaticus major, everything will be affected. So this has to be brought back to normal. This is what the concept of Delaire. Next one, please. And this is for the palate. Again, concept of Delaire concept. He says that extremely important Delaire jetplasty to get the muscles back into the position, as well as lengthening the palate as well as the posterior part of it. Next one. Just showing that, this shows that how a bilateral cleft lip, the muscles can be deformed. It will not reach the midline. The prolapbium has no muscle at all. It is on either side, it stops. The patient's prolapbium will start to grow anteriorly, uninhibited, coming forward like a proboscis. And this is what the second picture shows what Delaire want to achieve it. He says, get the muscle back to normal, most of the problem is solved. Okay? To create a highly symmetrical and functional lip. Very important with it. So the question is whether you are looking into cosmetic versus functional. That is very important. Next one, please. Okay, this is just showing that, how the Delaire concept work. He said many times, correct the lip along with the soft palate. This is his concept, Delaire concept in this thing. Correct the lip along with the soft palate. Anterior hard palate, he goes after 2 years and correct it. This is the Delaire concept. I don't do this. Many people don't do this because of certain reasons. I'm talking about only Delaire philosophy because somebody asked the question. Okay? Because he says, if you can get the muscles in the lip and the nose perfect, and if you can get the soft palate muscles into the perfect way, the patient will have a beautiful face, as well as the speech becomes normal. Then you can concentrate the palate, anterior palate afterwards. Okay, next one, please. This is the same Delaire's concept. Look at it. What you're seeing is that it is actually not a proper cleft lip technique, but it is called as a lip adhesion. Why he did lip adhesion, Delaire? Because he says he wants to bring the muscles back to the normal position first. Doesn't matter what happens in the filtral area. Afterwards, you can correct it. But he wants to get the symmetry of the nose, symmetry of the lip. The muscular forces have been brought back into position. Next slide, please. And again, a bilateral cleft lip according to the concept of Delaire. Next. So 2 principles, very important. He mentioned that bring the structures of the muscles, including alar cartilage, the nasal oral laterals, everything back into the position. Get the symmetry, the muscle. He always talks about the functional closure. Always talk about the functional closure. And of course, he also said that there is no using too many splints and everything, because as far as Delaire concept, the muscle is very, very, very important. Okay. Next one, please. We will take the questions at the end. Next one. Okay.
The next question is, can rapid maxillary expansion be done in cleft lip and palate patients?
Thank you for the question. Yes, the answer is yes, you can do it. There is absolutely no doubt about it. One can do it, always you can do it. The question is when we do it. The best, of course, ideally speaking, the best is done when the age, during the mixed dentition, because that is the time the bone will be very soft and, as that permanent teeth erupt, the best thing is to do that. Okay. So was it surgically rapid expansion or just a transverse expansion? What was the question? Sorry. Can you go back to one slide earlier? One slide earlier. Before. One slide earlier. Okay, it's just maxillary expansion, rapid maxillary expansion. Okay, next slide, please. So the rapid maxillary expansion in a cleft patient, yes, it can be done. There are two ways of doing it. One, non-surgical. Second one is surgical. So if it is a non-surgical, it will be like using something like Hyrax appliance and a lot of modified, nowadays a lot of modified appliances which can be used to expand the maxilla. Okay. If we use a non-surgical expansion, it is a non-surgical slow expansion by using this Hyrax. And it will be like a 50-50. That means 50% of dental expansion, 50% of skeletal expansion. Okay. Ideally done, best is at the mixed dentition. You can do permanent dentition as well, but it becomes more difficult when the child is grown into adult. Doing an expansion becomes more difficult for an orthodontist. This is what my orthodontic colleagues tells me. Do, yes, very minimal correction, very minimal expansion, we can do it, even in adult without any trouble, but to a limited extent. More than 7-10 millimeters is going to be very difficult to do it. Okay. Surgical versus non-surgical. I will limit the surgical expansion purely, if possible, in the adult where you have severe transverse deficiency. Mild transverse deficiency can be easily managed with a normal, slow expansion by using simple appliances. There is a question of fistula. Will you create a fistula by doing expansion? Yes, sometimes that can create. You have to deal with it later. But if there is a primary closure, you will get a secondary fistula. You will never get it because slow expansion can actually stretch the palate without any trouble. Okay. And I already told you bone versus the teeth. Severe constriction, if you need a bone expansion, then you have a surgical assisted palatal expansion. Okay. Next. And there are some, next one, please. And there are some ways of doing it. You have to do a leaf out one. Then use a dedicated palatal expander, which can be used to fix by using mini screws into the palate. You can see that. It is actually a dedicated one. This is a skeletal expansion, not a dental expansion. Okay. So both the cleft palate maxilla moves sideways. You don't have to down fracture a maxilla, but at least you have to make it mobile. Probably you have to do it little pterygoid disjunction. The maxilla have to be mobile to move it onto the side. Next one, please.
The next question is...
Okay, question number 6. I think this is the last one. Yeah.
Yes. So the last question for this day. Does catch-up growth occur in every Pierre Robin sequence patient without any associated syndrome eventually? Or is orthodontic surgery a must after growth for such patients? Also, how does it work for a PRS infant with an associated syndrome? Dr. Manigandan?
Thank you. The first part, as all of us know, already we mentioned about it. There is a triad of glossoptosis and that mandible is smaller and the tongue is, obstructing it, severe respiratory obstruction associated with so many other syndromes is being expected. Okay, next one, please. And you can, in our experience and world over, they have found that one thing, that there is no way, I'm talking about whatever the literature, I'm talking about whatever the experience we have in the last 20 years with Pierre Robin sequence. Okay, there is an increasingly high evidence that the mandibular catch-up growth is very, very unlikely from childhood to 20 years. Okay? It is very difficult. We have done so many patient distraction. Even with the distraction, the mandible never grew to the extent that it never picked up the growth like a normal patient at the age of 16 or 18. So that means that whether you're intervening either by means of a distraction or by functional appliance or by any means, it is very difficult to predict in PRS, Pierre Robin sequence, the mandible is going to grow normally. So that means a child from age of 0 to 20, if you take it, the adult who is grown with a maxillary retrognathism probably may end up in some form of surgical treatment in the adult, like bilateral sagittal split osteotomy. Okay, there's no question about it. But there's one thing people are studying now, that whether the intervention of mandible can also produce a growth of the maxilla better way. There are some studies going on, and they said that if you can intervene early in the mandible, the maxillary growth also becomes better. Because if the mandible is not growing at all from the childhood, there is a likely evidence that nowadays that the maxilla also will not grow. Okay, so there is a little problem of functional theory for both maxillo-mandibular relationship. There are a lot of studies are still going on, but many people are now going against distraction of PRS mandible because of the injury to the nerve and other tooth bud from the childhood. So many are discouraging and trying to find other ways how to make it grow. Okay, like orthodontic treatment and other things which we are trying to find out nowadays. So answer to the question, first question is that yes, you may have to probably intervene in the later stage. Number two, in syndromes, it is going to be the same. It doesn't matter whether the child has a syndrome or not. Mandible growth continues to be the same. Thank you. And this is one article which explains the biomechanical and the morphological analysis of Pierre Robin sequence in a very long study. It's a finite element study, but I have done a wonderful series of review. One can always go through it. It is October 2020. One can always go through it. It's a beautifully explained what happens as the child grows and what to be expected, the muscle effect, and so many other things. Thank you so much.
Thank you, Dr. Manigandan, for answering the PGs and clearing their doubts. But I still think we have a few more questions. Yes. So Dr. Sakpai has asked, sir, does the Delaire concept would also not work without rotation advancement? So what is the primary difference between Millard and Delaire? Sir, I think you already explained
that's what
this.
I've already told that. That yes. is, see, the Millard concentrate on flaps which have to be absolute symmetry. The radical dissection does not happen in Millard. But in Delaire, the radical dissection happens, he wants to go up to infraorbital level, dissect every muscle what is possible and get it back into position. That is the primary difference between Millard versus Delaire procedures.
So the second question he's asked is, like a cleft lip palate patient is coming to you maybe when he's 17 years old and he's got maxillary hypoplasia, but the patient has also undergone some treatment.
Operated, unoperated?
He's unoperated. Like the cleft lip, I think the primary lip and palate has been done, and he's also undergone a operated. He's also undergone a pharyngoplasty, and now he's come to you with a maxillary hypoplasia. So what will you do?
Treatment-wise?
Yes, treatment-wise. What would be your treatment?
I will, of course, hope that the cleft alveolus was done. And 17 years is the time that the fag end of the growth. So the first thing I will do is that I will examine the patient properly and see whether the cleft alveolus is done. If not, probably I might do a cleft alveolus. Of course, the patient has to be seen along with the orthodontist, see whether there's a transfer discrepancy, anteroposterior discrepancy, what is the discrepancy, how much is there. Then do a study of the OPG, cephalometry, and all those things. Then what we can do is that you plan staging, whether you wanted to do a secondary alveolar bone grafting, whether the maxilla is deficient or the mandible is prognatic. If the mandible is prognatic as well as the maxilla is deficient, After associated cleft orthodontic treatment, probably you have to do I know that pharyngoplasty also was done, correct? Is that what they mentioned?
Yes.
Yeah.
Yes, sir.
So if the speech is good, we don't have to worry about it. Okay. But if the speech is not good, already pharyngoplasty done, that makes it very difficult. I will never tell the patient that at the age of 17, I will make you speech and you can sing like SPS. You cannot do that. It's very difficult. You never promise a patient after 7 years, 100% you can bring the speech back to normal. It's very difficult to do it. So that is ruled out. Number 2, correcting the orthodontics. Yes, it is possible. Orthodontics can be done at any age of time. You can do it. You can align it, crowding, decrowding, compensate, expansion, all these can be done. Third one, skeletal correction. Okay. Skeletal correction, I already told you, if there is a severe maxillary deficiency, mandible is normal, you can do either a leaf-foot-one osteotomy after, but even at pharyngoplasty done, it doesn't stop you from bringing the maxilla forward, please remember. It doesn't stop you. It is still flexible to do it up to 7 to 8 millimeter. You can boldly bring it forward, even with the pharyngoplasty done. Absolutely no issue. I never had a problem. Or you can do a distraction osteogenesis of leaf-foot-one. If you're still not happy, you don't want to, speech is very good, you don't want to disturb the pharynx. If all other factors are good, you can do an anterior maxillary distraction. Some cases, severe discrepancy of maxilla and the mandible, you have to do probably maxillary procedure along with the mandibular pushback along with it. This is the final one. And once all this done, that is the alveolus is done, the orthodontic treatment done, skeletal relationship is corrected, do the rhinoplasty at the end of it. And that is a sequence I normally do it. Thank you.
Thank you. Thank you, Dr. Manikandan. I think those are the, we have just had 2 questions so far. I think we can just go now on to the next Ask Your Mentor session. And this time it is on aesthetic surgery.
Thank you. Thank you.
Yes. Thank you. Thank you so much, Dr. Manikandan.
Yes, madam. Yeah.
Yes.
We'll start the session. Yeah. I have to share for my laptop, or it will be a common sharing.
I'll do the sharing. Just give me a minute, please.
Yeah.
Can you see the screen?
I can see you, madam. Yeah.
Sorry.
Not sharing. Yeah, we can see now.
Yes. Can you put in full screen, ma'am? That's
Yes.
Yeah.
Yeah.
Yeah. Thank you.
Okay.
So
Yes.
Yeah.
Your next mentor is Dr. Yasser Arafat, and the topic is on aesthetic surgery. So we didn't have a wide variety of questions. Rather, we had more questions relating to one particular topic, that is about fillers. Okay. And away from fillers, we had 2 different questions, one on mesenteric hypertrophy and the other one was on microneedling. Okay, so we have a very good explanation from Dr. Yasser Arafat. I'm sure PGs have not much idea about how aesthetic surgery is done. So this will be slightly different from the previous session wherein I was asking the question and Dr. Manikandan was answering. In this part, in this next series, Dr. Yasser would explain to you on how the procedure of fillers is done and on the various fillers. So it's like more like a presentation that he's going to do. And once he's done with it, you have any other questions, then we'll take it up with Dr. Yasser. Okay? Yes. On to you, Dr. Yasser.
Yeah. Thank you so much, madam. Yeah. I thank Jimson sir for giving me this opportunity. It's been a wonderful session by Mani sir, and it's like I went to my PG days where all I refreshed, and it is excellent surgical session. And after that, I'm going to talk about something which is nearly in existence in most of the maxillofacial practices. And it's more of a clinical oriented, it's clinician oriented, and it's fast picking up. Unfortunately, I didn't got enough questions. I waited for a week, and finally they landed up in a few questions that more relevant to fillers. And I just want to share some ideas how to proceed about the cosmetic practice. Actually, the topic is cosmetic surgery, but I didn't got any questions on that. Okay, let me explain whatever the questions I've asked to the relevant point. Next slide.
The first question was related to mesenteric hypertrophy. So Dr. Yasser would explain on it.
Yeah, the mesenteric hypertrophy, they asked about the how to do, and there is very good article by our Chinese colleagues where they exactly, the next slide, man. Yeah, this one, mesenteric hypertrophy happens because of various reasons. I don't want to go deep into that. But before arriving at a conclusion, it's only because of the masseter, which has been hypertrophed, maybe because of the habit or some sort of genetic predominance. So we have to check whether there are not any bone pathology before doing the procedure. Usually for mesenteric hypertrophy, you have to mark the safe zone that runs between the corner of the ellipse and to the pin of the ear. And from there, you have to plot a line. From there, you have to ask the patient to plunge and mark the anterior and the posterior border. The superior border will be the line connecting the corner of the ellipse to the pinna. And the lower will be the inferior border of the mandible. The safest zone to inject is a 0.5 centimeter to 1 centimeter around the muscles, evenly distributed. You have to go deep. One slide before, ma'am.
Yes.
Yeah. So if the width of the masseter is 3 to 5 centimeter, then the dosage will be 20 to 30 units of botox K toxin. It will be correctly pointed around 4 corners, and you have to give it off. And you have to repeat the procedures every 3 to 6 months. As everyone knows, the botox effect lasts for around 3 to 6 months. So it depends on the patient needs. There is no standard protocol that you have to inject this much and you have to wait for it. But you get the result only after it starts showing the result after 3 to 4 weeks, and it stays up to 6 weeks. So that's the only question I got on mesenteric hypertrophy. Next slide, man.
Can I just ask a few questions related to that?
Yes.
Okay. Now we said that mesenteric hypertrophy, the treatment is Botox, and Botox, the action of Botox is basically it inhibits acetylcholine release, and thereby it sort of makes the muscle, the activity of the muscle less. So through that it becomes hypertrophy.
Yes.
So that's how the muscle bulk reduces.
Yes.
Now you have showed the safety zones. Is there any precaution that we need to take? Like what are we looking at other than the dosage? What is the depth of injection or anything we need to be careful about in case we go too deep or too superficial?
Yeah, that's what. First you have to hit the bone. You have to take maybe a 26 gauge needle, maybe an insulin syringe with very fine tip, and you have to go hit the bone, and you have to withdraw a little bit of around 1 to 2 mm, and you have to feel the muscle as the patient the clunch, then inject a dose. Even if suppose you say you mark 4 points, inject 10 units in 4 points. And before doing any Botox or anything, check for the allergic reaction to Botox, and that is far most important before using the Botox injection. Okay, yeah.
Yes. So now the next topic.
And one more point, I marked a thing which is called the posteriormost point, that is the red color marking. Yeah, that one. Yeah.
Yes.
So that is the posteriormost point of the mandible. That is a posterior margin. And try not to go deep into that. You might injure the parotid. So it causes there will be a transient dysfunction of the parotid gland also in that area. So that area is marked in a deeper red color. So anything you have to do 1 centimeter away from the boundaries. That's what you have to do, right? Yeah.
So the next set of questions were related to fillers, and Dr. Yasser will talk about fillers on a broad basis. Okay?
Yeah. So actually, Sir talked about all the great about the cleft surgeries, and it's amazing to see that he's done more than 9,000 surgeries in my lifetime. I don't know whether except cleft, I've done a lot of went to a lot of training in other aspects of maxillofacial surgery. I don't know about cleft because something hinders me from going to this. More of a academic concept. I'm a 100% clinician, so I move around a lot of hospitals and do a lot of things which more relevant to day-to-day practice. And since this session is for from the PGs and for the PGs and the postgraduates who are training, they might not be aware of the most of the procedures as we do clinician. Second thing is, as a maxillofacial, we are not being exposed to so many these sort of minimal surgical or minimal traumatic procedures, which has been in existence with cosmetology come dermatologists. And for the kind information, we are the masters of the face, but we are not using our full potential in the aesthetic aspects. So I want to elaborate few things. See, they asked about the fillers. A fillers of its own, it's a big subject. You will know after this few slides, I give some explanations how to tackle a case, how to see a case from a cosmetic aspect, aesthetic aspect, and how to convince a patient further for the treatment. So for any fillers, like how you do orthognathic surgery or you do a cleft surgery, there is a lot of rules written, and there is a lot of articles which will be published, a lot of big authors, big surgeons who has formulated with their experience, and all they summed up in an article. The same way, the fillers, they did a lot of studies, a lot of research, and they formulated a certain points, okay, where you need to inject and where you have to inject so that you can get a consistent result in any part of the world, in any patients you need to do the treatment. So one of this is MD codes. He is the godfather of the filler. The filler you commonly use is hyaluronic acid fillers, and he's a godfather who has mastered this technique with so much of his experienced patient, and is given a lot of techniques and points where to inject the fillers to get a consistent result. You can promise the patient that you can give some sort of good cosmetic result to the patient. So that is very important. So this article you can just download. It is the latest article which has been published about these codes. And these codes has been marketed by Allergan Pharma, who sells most of the internationally trusted fillers. So you can just note down this MT codes. This article and the methodology are there online. Next slide. So this is Allergan Pharma. This is, if you want, I can just send the PDF format, or I have a soft copy. How to revitalize the face with minimal or nearly non-traumatic surgical procedure, minimal surgical procedures. Step-by-step guide. Okay, if I want a crow's feet correction or a lift or a facelift, which is done non-surgically, these points are given, and we can follow it to get the exact result. So next question I got it, what company you have for the fillers and what are the fillers? Mostly I do only Juvederm. Juvederm is Allergan product, and one more is Restylane. Both the fillers are the trusted products. And one more thing is, you can just go around. We have fillers for different areas of the face. So one fillers doesn't suit in all the areas. For upper face, there is a filler. For volume correction, there is a filler. For fine line correction, there is a fillers. Just to mold the face, there is sort of fillers. You have to play around it. Actually, the filler itself, it's a big subject. So these are the types of fillers the Allergan Pharma is selling. You see that there's a Juvederm Voluma with lignocaine, which is used to restore the volume of the face. In that way, a lot of fillers are there. I just go to the next slide so that we can. Okay, so in that MD course, they recommend some fillers for men as well as for women. So these fillers, which gives a feminine look and men's look, so they have been formulated for men and women also. And some questions they ask, where to use needle, how to use needle, how to use cannula. These also formulated. You can't do a cannula in all these sections of the face. You can't do needle in every section of the face. So it depends. See, injection of Juvederm Voluma, we have to use only 27 gauge with half sterile, needle. In the recommended gauge, only we can use it. So we get a proper, the proper shape of the what you want to achieve, the volume we can achieve. Yeah, next one.
So basically, you're saying needle can be used for finer or thinner areas when compared to the cannula?
Yes, madam.
Okay.
See, if I say, for example, we want to correct nasolabial fold, right? There we need a linear deposition of the materials. In that way, you can use a cannula. For deeper layers, if you go into the deeper planes, then you have to use a needles. You have to play with it. So that also is explained with MD codes. Where exactly you have to use needles, where you exactly use with cannula, what is the depth, what is the point, everything is being mentioned. Next slide. So see here, I have just only put the MD codes. In that you see they mentioned that how it should be injected, like small bolus or linear or fanning motion, or aliquot or microaliquot, like that. And if it is a microaliquot, how much to inject? All these terms are mentioned in the MD codes. So fillers, we can't take as a subject. Okay, we can't explain in a or 40-minute section like all the things to the participants. So it give a broad idea how to go about fillers. So targeted sections, either it can be a dermal or a mucosal or subcutaneous fat planes or a supraperiosteal injections. So as a general rule, aspiration is highly recommended using fillers. Avoid scratching the periosteum and massage gently. If you are using in the deeper layers, you need a robust massage. If you deposit the fillers in deeper layers, the muscle plane or the periosteum, that area it will be tighter. So if you don't massage vigorously, it get deposited and it leads to a nodules. And it gives an ugly look to the patient. The patient comes back next day and he'll be complaining. I tell you that not even a big traumatic patient will disturb you like that. This cosmetic patient, they pay you for it and they'll disturb you like anything. Every 2 hours they call, okay, this has not been correct, there's something wrong and your face been swollen, all these things. So you have to master it correctly. It's not an easy go to do a filler at first. We need a lot of training, I personally gone through a lot of these small courses. Some plastic conferences, even I went to dermo cosmetology conference, you say you are a dentist come maxillofacial, they don't even register. To be frank, I usually lie to them. I say as a cosmetologist, something else. I just go register, sit there and learn and clean. So a lot of things are we have to implement and we have to get the result.
Just
okay.
Asking or just adding a point.
Yeah.
Like we have different filler materials based like hyaluronic acid or other things, but like calcium hydroxylapatite and methacrylate.
Yeah.
So common one, and for a person who's starting on early, it is best to use hyaluronic acid.
Yes.
But rather than going in for the other sort of filler materials.
See, other sort of filler materials are really become inexistent because if we go for hard tissue fillers, the story is different. We have a lot of options are there. Soft tissue filler, the current scenario is only hyaluronic acid. No other company produce other fillers. Some companies are even using our suture material, polyacrylamide and that combination they're using. Lactic acid. Yeah, that combination they're using. But all are being outdated. Now the concept is only hyaluronic acid with the different molecular weight. So if it is a fine line, there will be a low molecular weight. If it is deeper structure, you want to hold the volume, there will be a molecular weight will be more. So it's like that. Yeah.
So just based on the molecular volume, whether we can have a little bit of fillers or more.
Yeah, that's what.
Areas.
Yeah,
deeper or superficial.
Yeah, it's a huge inventory you have to invest first of all, because if you want to treat a patient, you can't just add on one filler. All right. Yeah. See, in that next slide, you can understand. So much of fillers, we have to do it in a different ways and different planes. You have to deposit a different kind of fillers in a different planes. That gives a good look to the patient. So that's a concept. Yeah. Next slide. See, MD codes, if you want to treat the face, see, so much of predetermined, pre-programmed facial filler formulation has been given. See here, there's an 8-point lift, a 5-point, if there is a cheek that has gone in with the atrophy of the face, 5-point cheek reshape, 3.48 reshape. You can just go through it and beautifully explain. You just need to take a printout of that or keep a laptop in front of you, and you have to mark the point, inject, do as they say, and come back. You will get amazing results. This is like how to interpret the point, the markings or the points. Say the letter, the anatomical area, like example, it's a cheek, they mentioned as CK. If it is subpurine, if it is a cheek area, it will be a zygomatic arch or maybe an eminence. So in that CK1 or CK2, it's how to interpret. I'm just telling it. And the number is, they mentioned the 1.1, 2.3. If it is an upper, there will be a superstrip. If it is like a Venvian border of the upper lip, if it is a lower lip Venvian border, there will be a subscript. And the red dot denotes the critical anatomical structure like blick vessels, which is in that area, and we have to be alert in that area. And technique of delivery, technique and the needle or cannula, whatever, we have to use it. That is being mentioned in the MD codes. Yeah. See, these are the basic points. The red area with that triangular point. You have to be, if it is a red color, that means you should be alert that there is some sort of important structure, that means a nerve or a vessel which is running there, and I have to be careful in doing that. And the depth of injection they would have mentioned. So if it is an 8-point lip, where to do? Next slide, you can understand how to inject for an example. Next slide now. See, if it is, they given a red alert. So there is in that case, superior labial artery is running in that area, and there will be infraorbital vessels in that area. So we have to be very careful in that injecting in that area. Just like that, we can't do that. Yeah, next. See, it is a checklist for treating a facial deficiency. Okay, there is plenty of way to do. Surgically, you can lift it, the smash planes or surgical procedure we can do. This is a non-surgical or a minimal surgical way of doing the procedures. Basically, you have to do a foundation. Okay, foundation means you have to building the fatty layers, which is the holding the face as they mature, it sags because we lose the fat and we try to deposit face because of gravity in the lower half of the face. So we have to rebuild the foundation in the cheek area. So cheek area is the foundation. Then contour of the face, it's like your temple will be sunken, or the lower face where the chin will be a double chin and jowl area. These are the contours, the corners of the face, the edges of the face. That is contour. So basically, you have to segment it like foundation, the cheek area, then the peripheries like a temple or the lower contour of the face. Previous slide. And refinement. Refinement only comes where there will be a fine line like teardrop or nasolabial fold or nose reshaping, or all these comes in a refinement. So basically, if you're seeing the patient, first you have to go for foundation, and then you have to go for contour correction. Then you have to go for refinement. These are the basics of any fillers. But keeping in mind, we can't use all the fillers at all the places. You have to select the fillers according to your patient's diagnosis, the patient needs. Yeah. Next slide. See, suppose this algorithm, you see here, saggy cheek. Okay, you have to analyze whether it will be a lateral, anterior, or medial. So if it is a lateral, upper cheek or lower cheek, then they mark the point. Cheek 1. If it is only the upper cheek, you have to only inject in the zygomatic arch 1, cheek area 1. That will give a good look to the patient. Next, if it is a lower cheek, you have to do it in 2 places. In the same way, if it is an anterior, you have to do it in 2 places. So all these things, you see only for the cheek, you see this algorithm. Next, man. If it is a sunken temple, whether you have to go for either it will be a mild, severe, or skeletonized, then you have to, so mild, just we need to do it in temple T1 region. And if it is severe, T1 and T2, if it is skeletonized, all the places from the bone till the fascia, you have to give the fillers. Yeah. Teardrop, again, there is a series of protocol which has been see that we have to diagnose it properly and we can follow it off. Yeah. Next one. Eye bags. So this is a big, these all things you have to sit and you have to master it before. These you can't learn from the a standard a curriculum of maxillofacial postgraduate curriculum, because it has not been introduced. Maybe in next surgeon, next group of surgeons might bring this in, and that will be a huge difference. It makes a huge difference to the maxillofacials, because we are dealing so much of surgery, starting from the scalp to the neck. We are doing like anything, we are doing surgery, but we are not concerned about the cosmetic aspect of the face. That is very, very important, because that is the one which gives the final outcome. Yeah. Next, man. So this is an 8-point lift. I don't want to waste time. It's like, if it is one, that only one I want to mention here is, if see there is with only the 8 points of fillers deposition, we can give the face a young look. A older person, we can make them a little younger. So you see there is an 8-point lift. The point they marked, you no need to remember. These are not for to remember or mugging or something like that. You need to sit with the patient, just follow the instructions, what they mention, just deposit the amount, what they mention, just do it rightly. You will get 100% result with 100% satisfaction from the patient. But you need to do it repeatedly. You need to undergo a lot of training before doing that. Next one. So this one case I would mention. So, okay. So this lady is around 43-year-old and dull, aging look. Always she feel like she is so much of tired looking, and someone sees her, always ask her, why you look so tired? Okay. So why can't we correct the patient? Documentation is very, very important. You have to take a clear picture of the patient and you have to document it, so that these cosmetic patients, even the fillers, you know, the 2 ml volume of fillers, Juvederm cost you around 18 to 25,000 rupees. So if you are using four different varieties of fillers, you're going to somewhere, you're going to, from your pocket itself, you're going to put around 80,000 rupees. So patient, you have to charge at least 50% extra. So your documentation is much important. You need to show the patient the result, okay, the pre-op and post-op, and we have achieved a lot of difference. Okay, see, now what I did is, for this patient, we correct first injection. This injection has been taken only with mid-face foundation. Mid-face is this one. That is the foundation for any fillers. You see, we injected a good amount of fillers in the cheek region. So you see, Immediate result, a plumpy appearance looking chin. Next. And now, second thing, see, it runs like that. First, we did a foundation. Next, contour correction like temple and the lines, the edges of the faces. Okay. See, immediately from the, we just pointed on the pre and post op. See, dull looking till you see a good. We are trying to reverse the age. We are making her to feel as if she looks younger. The confidence of that lady has boosted immensely. This patient, one thing I want to say, like you can do it at single stage if you are very confident, or else you can use the fillers with one foundation. You can ask the patient to come back after a week or so. Then we can do one by one. Yeah. And contour of the lower face. So this itself given her a good look. Next slide, man. And finally, the refinement of the contour. Some additional fillers on the contour correction and fine lines. Okay. So from here to here, for me, she look pretty. And at least we reversed 10 years younger. And it's good, right? Next.
So I think if I'm seeing this picture correctly, that once you've given fillers in the zygomatic region, maybe the chin you've corrected, and where else?
Forehead, chin, and here angle of the mandible, and fine nasolabial fold, tear trough. All these fine lines, all has been injected. She is carrying around 20, at least something around 16 ml of fillers in her face. Yeah. So next one. So whatever they ask the question about fillers, I don't know who has asked that. The teacher has asked. They don't know to formulate itself the question. So I have just made a fillers, an outline of the fillers, how to proceed about it. But we need an elaborate session for it to only on that. That we'll see later if Sir Jensen sir and Avan permits me to do so. And one more question they asked is I don't know why they mixed up fillers and doses, and say they asked about eyelid doses. It's all see after Botox. Sometimes if you are using for forehead wrinkle correction, or in between the nose for especially for the fine lines in the middle of the nose. Yeah, it slips in. Yeah. Yes, ma'am.
Yes. No, why does ptosis happen following Botox?
Yeah, basically there is a forehead correction, wrinkle correction. That is a problem. And you have to be very precise in your location of injecting the Botox. If you miss the plane, it overflows and it causes ptosis of the eyelid. And even it happens, the effect lasts only for 4 to 6 weeks and it can be managed. For time being, we can give an alpha to adrenergic agonist to reduce the pressure on the eyelid, and it keeps them okay for some time. But it reverts back because the Botox action are very, very short-lived.
So, is there any particular way to avoid eyelid ptosis when you're injecting the forehead?
That's what you have to mark the point, and you have to lift the muscle, and you have to do it only on the muscle. If you slip the planes, and the extra bit of Botox, which comes and it just flows down and it goes to the eyelid. That's what, it depends on the operators. It doesn't happen to everyone. You keep doing that, it comes. Yeah, sure.
The experience, yes.
Yeah.
So the other question was on micro needling. I think from
so they asked about the uses of micro needling. So okay, see, micro needling it's become standard of care in all cosmetic centers, but they are not using micro needling alone. To be precise, they are using RF micro needling. We are using RF micro needling. The radio frequency energy which goes through the microneedles and through the micropunctures, it goes inside and it gives that energy and stiffens the collagen. That is the concept nowadays. So microneedling alone will not give an effective result. So that is the concept nowadays. Yeah, and uses they asked about, it can be used to treat acne scars, age spots, fine lines and wrinkles, other scars, and to stiffen skin. So that's the thing. So next is, see, I just want to tell you about the cosmetic procedures. See, the topic is cosmetic surgery, but they asked only about this, the superficial procedures. So no treatment modality recommended for, one treatment modality recommended for facial cosmetic procedures. Always combination of procedures. Suppose a patient walks in my clinic, it can be a surgical, minimal surgical, non-surgical procedure used in complete management of patient, and even touching the patient, I check for their deficiencies, I'll go for medical examination, and I also use the products. Documentation and informed consent is utmost important. If you are not documenting, you are informed, you are not informing the patient, get a proper informed consent, you don't do a cosmetic procedure, it leads to medical legal problems. And all these cosmetologists and the plastic surgeons who are already in the track, they are waiting for the chance to do something on you, right? So better document it and get an informed consent. It's a facial cosmetic procedures. It's subject of its own. I just personally recommend, ask the superiors to introduce some sort of cosmetic procedures in PG practices so that they can be aware of that. Yeah. Okay. Yeah.
Yes. Cosmetic procedures, I think, like how Dr. Yasser said, it requires a lot of experience, and important things that you really need to follow is proper documentation, and make sure that you have some good pre-operative photographs of the patient, prior to doing any procedure. Because I've heard other surgeons also say that in case the patient has some sort of asymmetry in the face, or say a mild ptosis, which they are not, don't realize they have that. So taking a proper pre-operative photograph and then telling them that they have this problem may avert any sort of medical legal problems that you might face. Okay, Dr. Yasser, we have one very enthusiastic participant who's asked quite a lot of questions. Can I go ahead and ask those questions to you? So one is he wanted to know where you got this guide chart. So he wants you to share the dose and depth of penetration. So I think maybe he can contact you later and then collect it from you.
Yeah.
And regarding fillers and Botox, he asked, is it mandatory to use fillers with Botox for every case of facial sculpturing?
Botox indication is, see, that's what, see, suppose if a patient walks into my practice, it's like a multimodal treatment. Botox and fillers will not do for all the cases. It's like if you have to go for sequential medical history, and all this history is very, very important. And what they expect actually, and the age group of the patient. If it is an older patient, more of fillers you can use, right? If it is an older patient, there will be a fat loss and you can use more of fillers. And some areas where fillers will not work at all, like if it is like a forehead or if it is like a crow's feet, then there is a big thing we can use it as a Botox in certain indications are there. So we can use it as a combination, but not at the same time. We have to sequence space the individual treatment timing, and we have to, based on that, we have to see if it's a patient walks into my practice.
So So this is basically depending on what the patient wants, because facial sculpturing is considering the face as a whole. So depending on some certain areas, like you said, sagging, then they would require some fillers. And when there is a lot of wrinkles.
Now, one important concept is, if it is an upper face, fillers will, the Botox will works better. Lower half of the face, because of the gravity, the fillers, we need to give some volume, then fillers will work. That is a general rule, but it can be mismatched. As Mani sir said, surgery goes, if one technique goes very good with one surgeon, one surgeon can't pick up the technique at all. Depends on individuals, the experience. right? So, as I say, don't see a patient only for fillers and Botox. That's what I again and again tell you. You have to see use of products, nutritional deficiencies. You have to even do a smile design, smile correction. The minimal surgery might be needed, a non-surgical, even the trichology, the hairline definition, follow-up maintenance, all are like we do a patient like a management. It's like we give a protocol and set some time frame, and we deal the patient in that way. Yeah, right.
So again, another question related to Botox, Dr. Satva. I'm so sorry. She asked regarding your experience regarding mandibular dystonia. Have you used Botox for mandibular dystonia? And where do you inject the Botox? And should we use fillers in such cases?
Yeah, that's what I have never used it. So my patients are usually like a clinician aspect. Like it's not an academician where I used it. Sorry, I never used it. Yeah.
Okay, so basically,
Yeah.
mandibular dystonia is a muscle which sort of have
So
hyperreactive muscles.
I never used it. Sorry, I didn't got such sort of patient.
Okay, now moving away from Botox or fillers, we have a question on lipo transfer. So I think when you do a liposuction or this thing, we want to know why do we get boils or infected site after abdominal fat transfer to malar region? What will be your foolproof?
Oh, they're asking about the infections on autogenous fat graft transfer.
Yes.
That doesn't happen. Why it should happen? Maybe they are not disinfected, or maybe they are not painted. They didn't prepare the skin properly. Otherwise, it doesn't happen. Why should it happen?
Yes. So
It will not happen.
stability.
Yeah. The fat graft, the autogenous fat transfer is the best way to give a patient because it has a pluripotency. The fat can transform into any sort of tissue. So this even the hyaluronic acid that it works for a year or 2 years for some patient. That's it maximum. Fat graft stays for a long time. It gets transformed to a fibroblast or whatever the cells which dictates that area. So that is best way to do. Infection in that area is, I think it's because of the not preparation. The preparation is not done properly. That's it. Yeah.
So another question is on lip lift. What are the less invasive to more invasive techniques for lip lift? And your experience regarding the two elastic thread technique, and are there any complications associated with this technique?
Yeah. Lip lift, you have to analyze it. If it is a muscular sag or something which is the laxed muscle, thread lift will be better, or even a surgical lift will be better. But if it is only for a young a lady where they want a little bit of lift of the Vermeer border, then beautifully the fillers will work. That's what you have to analyze the patient, what is the need, and you have to see which works best for the patient. Yeah.
Okay. The last thing is just telling you that you've presented a wonderful case, and he's very happy that you shared his pearls on with you.
Thank you.
I think with this we end our asking a mentor session. Over to you, Dr. Zimson.
On behalf of the organizing team, thank you, mentors and moderator, for giving us valid input and for aiding enhanced learning as well as understanding of today's topics. We look forward to seeing all the participants again during session 9, scheduled to be moderated by Dr. Karthikeyan and mentored by Dr. Saravanan and Krishnan on the topics Diagnostic Investigations, Nerve Injuries, Neuralgia, to be held on Friday, the 23rd of April. Fill the feedback form that will be posted shortly. Participate in 8 out of 11 sessions to get a certificate. Thank you all. Thank you, mentors. Thank you, moderator. Have a good night.
Thank you, Manish sir and Yasser for the fantastic explanation and as well. Manish sir, I think you have crossed 9,000 and looking forward to you crossing Sunil Gavaskar's record of 10,000 runs. Yeah. Sir, are you there?
Hello.
Manish sir, are you there?
I am here. Well, yeah.
Boycott's record of 9,000 odd runs. Now, looking forward towards beating Sunil Gavaskar's record, 10,000.
Okay. Thank you.
Thank you, sir. Thank you.
Thank you, Manish sir. Thank you, Dr. Yasir.
Thank you, ma'am.
Thank you, Dr. Vimla. Thank you so much. That was wonderful. Thank you so much.
Thank you so much.
And
Thank you, Jim.
thank you, sir. And to go with the announcement made by Mrinalini, we have a fantastic session on Sunday as well. It's on COVID and vaccines. So we are going through the second wave, and the panelists are from ICMR, Dr. Ashwath Narayanan, the Registrar of our University, and the Deputy Director of Health of Chennai Corporation, Dr. IAS Officer, Dr. Albie John. So hope to see you all on Sunday as well for some inputs regarding vaccine, because they are opening up the vaccine for everyone above 18 years. So I'm sure every one of us have some queries. They're open to discussion on Sunday, 11 a.m. It's live on Zoom as well as on YouTube. Thank you.
Thank you, sir.
Thank you.